Good evening, everyone, and welcome to our cardiovascular live prevention series from DEBAKEY studio. And thank you so much for joining us on this historical day. So rather than talking about politics, I can gain your attention towards something that's more interesting, cardiovascular prevention and how sweet it is. And well, the notion here is more around diabetes. In 2020, as we speak, right now, there may be 30 million diabetics in US, and the numbers, and if you add obesity, metabolic syndrome, about 50 to 60 million, and there's no sign of remission. Now, as cardiologists, it was always challenging that apart from glycemic control, whether we could do anything else from that standpoint to reduce the risk apart from the usual therapeutics, statins, aspirin, blood pressure control. But over the last decade, we have seen significant advancements in actually glycemic agents, and namely the glucagon-like peptide 1 agonist and the sodium glucose co-transferase inhibitors that have, over the last 5 years now, widely established significant improvement in additional benefits, weight loss, heart failure reduction, and actually reduction in cardiovascular disease. So for us now, these are not just glycemic agents, but also cardiovascular reduction risk agents. At the same time, we are facing a new challenge of adoption. And in real world, we suggest therapeutic inertia, that how can we get the right patient, the right medication at the right time? And unfortunately, nationally, locally, even at state level, about 3 to 5% of patients who are eligible for this effective event reduction agents are able to get it. Now, to carry on the conversation, I truly have the honor to have 4 distinguished guests with me today. Firstly, I'd like to introduce my co-moderator today, Dr. Archana Sadhu, who heads the diabetes program at Houston Methodist. She's an endocrinologist by training. And I have 3 luminaries, Dr. Darren McGuire, professor of medicine and heads the outpatient program at UT Southwestern, and Dr. Michael Blaha, a dear friend of mine from Johns Hopkins, professor of medicine and heads the CVD Prevention research program, and my colleague, Dr. Kershaw Patel, who just joined us from UT Southwestern, heading our own cardiometabolic program. So to start with, I'm just going to start with Darren. You have been at the forefront, literally, of this whole progression over the last 10 to 15 years, and seeing the whole development from the front seat. And just recently, your involvement in a landmark trial published in New England Journal, the Virtus CV. I think you would be the best one to discuss these results, and how would historically all of these data fit into the cardiovascular outcomes?
Yeah, thanks, Khurram, and thanks for having me. Really important topic, and of course dear to all of our hearts here on the program. And what's encouraging is it's getting more and more interesting to many of our colleagues in cardiology as we get more and more data, especially with the GLP-1 receptor agonist and the SGLT2 inhibitors, where we're really evolving from considering these primarily glucose-lowering medicines to actually cardiovascular medicines that also lower blood glucose. So getting into the SGLT2 inhibitors, so we've just completed the Virtus CV trial. This was a randomized trial of the SGLT2 inhibitor ertugliflozin. This trial was almost identical to the design of the IMPA-REG outcome trial. So everyone who entered the trial had prevalent atherosclerotic cardiovascular disease. We randomized to 2 different doses of ertugliflozin with a prospective plan to pull the analysis, just as was done in the IMPA-REG outcome trial. Interestingly, ertugliflozin pharmacologically is the very most similar SGLT2 inhibitor to empagliflozin, and so we had great optimism that we would simply be able to reproduce the findings from IMPA-REG outcome with this drug. The specificity for the SGLT cotransporter of ertugliflozin and empagliflozin are almost identical and quite different from dapagliflozin and the least specific canagliflozin. So now ertugliflozin, this is the 4th piece of a 4-part puzzle analyzing cardiovascular outcomes, safety, and efficacy of this class of medicines. So there are 4 available in the US. Ertugliflozin is the 4th one to be tested. So cutting a very long story short is we failed to demonstrate superiority with ertugliflozin on either the 3-point composite cardiovascular outcome, cardiovascular death, MI, and stroke. And importantly, and in contrast to IMPA-REG outcome, we also failed to demonstrate superiority for cardiovascular death alone. So very different outcomes when we're looking at the atherosclerotic related cardiovascular outcomes on which all of these trials were primarily designed. And I will say the trial was positive in the sense that we primarily designed the trial under FDA guidance and EMA guidance, primarily designed the trial to prove non-inferiority first of ertugliflozin. And in fact, we did, with a p-value less than 0.001, prove statistical non-inferiority of ertugliflozin versus placebo, but no incremental superiority on the cardiovascular, on the atherosclerotic outcomes. So in the hierarchy, we first tested for non-inferiority of Mace. We were successful. So then in a hierarchical analysis plan, we then tested cardiovascular death and hospitalization for heart failure, an outcome that was superior with dapagliflozin and declared 1058. In various with ertugliflozin, we failed to achieve statistical significance. The point estimate was favorable for the composite outcome, but the p-value was 0.11. So that stopped the hypothesis testing in the hierarchy. Everything thereafter becomes hypothesis generating and exploratory. But importantly, lining up in lockstep with all of the other SGLT2 inhibitor trials, we had almost identical effects, statistically significant, acknowledging that this is an exploratory analysis, achieving nominal significance for reduction of hospitalization for heart failure, a roughly 30% relative risk reduction for hospitalization for heart failure. And that lines up almost precisely with all of the other 3 drugs in 6 other trials. And then finally, as has been seen with the SGLT2 inhibitors across the class, is we had a potent effect on modifying kidney-related outcomes. We missed on our prioritized kidney-related outcome, which included a doubling of serum creatinine. But if we look across the other trials that all used a sustained 40% reduction in EGFR, which is a lower bar to achieve, we had almost identical effects of ertugliflozin on a kidney-related composite outcome. So in summary, we missed on 3-point Mace. We missed on cardiovascular death. Ertugliflozin did not reproduce the IMPA-REG outcome trial results, but it does look like a class effect, if one wants to call it that, for hospitalization for heart failure and for preservation of kidney function and mitigation of progression of kidney disease. So maybe I'll pause there and we can talk more about that a little bit later.
Right, so that's great. Quick question, just as a follow-up for you, Darren. Should the take-home message, and also Dr. Sadhu for you too, is does the agent within the class of SGLT2 matter now based on what you just told us?
Well, I think there are some differences. You know, the empagliflozin from IMPA-REG outcome has a FDA labeled claim for cardiovascular death. It's the only drug in the history of US FDA to get a cardiovascular death reduction claim as an individual outcome. So that's a pretty potent signal. Canagliflozin has an indication to reduce 3-point Mace cardiovascular death, MI, and stroke, and then subsequently a third indication to reduce progression of kidney disease. Dapagliflozin has an indication to reduce cardiovascular death and hospitalization for heart failure composite. So each of the other 3 have FDA product labeled indications. There are important differences between the data behind those and the language in the labels, but all of those have clear clinical indications. I think it's going to be a challenge with ertugliflozin what labeling may come from the Veritas CV trial. I think it's reasonable to request consideration of comment about hospitalization for heart failure, but at the end of the day, and I think this likely will impact third-party payers, the third-party payers are more likely to reimburse for agents that have FDA product labeled indications, I would suspect. So I think there's going to be a little bit of differential uptake. I personally still prefer empagliflozin because of the power of the cardiovascular death analysis. But I'll be quick to admit, you know, we've recently published a meta-analysis and empagliflozin is clearly the outlier in this field with all of the other point estimates of cardiovascular death effect lining up at a much more modest estimate of magnitude of efficacy. So it may be that IMPA-REG outcome somehow is a spurious outlier, and there's some, but not such robust effect on death across the class. But I would say at the end of the day, I would pick the one that the patient can afford, the cheapest out-of-pocket coverage. I think they're more similar than they are different. and it's probably not worth a huge expense out of pocket for the patient to nitpick the nuances between the 4 drugs available in the U.S.
I would completely agree. I think that it is a pretty believable class effect, and while there are differences in the FDA labeling, it really comes down to what the patient can afford, what their insurance carrier will pay. As far as their glycemic control, they all seem to have about the same A1C reduction, around the 1% range. As far as their side effects, they're very similar, so how you're counseling patients is all the same, and what you're looking for is the same. So in that instance, it really just comes down to the cost of the drug.
So while considering these applications, does cardiovascular risk reduction, especially mortality, does that play in your role while you are choosing
absolutely.
these medications?
Absolutely. First of all, just whether you use the drug or not, when there's risk factors or the presence of cardiovascular disease, that step is the biggest step. And then when we are getting further about which one and which has an indication, then we can be more specific. But just even using that class is a major change in our practice.
Well, when I started my practice, just building up some of the programs, it became an interesting dilemma for me at some point, and saying, well, if it was just an SGLT2 inhibitor, that would be great. Now we have other options, the GLP-1 agonist. I know, Dr. Blaha, you gave us a fantastic tour on how do you choose among the two, especially from a cardiologist perspective. Of course, there are some differences, and you have an ongoing program at Hopkins. I would love to hear your thoughts, and if you'd share your ideas and what we should, as cardiologists especially, look for while choosing between an SGLT2 and a GLP-1 inhibitor agonist.
Yeah, it's a great question. It's something that comes up all the time. Now, Khurram, would you like me to share my presentation? I have a couple slides on this.
If you have some slides, that would be great.
Okay, so let's pull that up, because it's a very relevant question that, of course, comes up in our clinics all the time. We have someone with diabetes and is at risk for heart disease, and we need to make a decision. But, of course, the drugs do differ in important ways. Let me just confirm. Can you all see my slides?
Yes.
Yeah, so let's go right to the table 6 from the ACC, the decision pathway for diabetes therapy. So this is a comparison of SGLT2 inhibitors on the sort of the middle column and GLP-1 receptor agonists on the right column. And there's some comparisons here that I think are useful for the practicing clinician. And the first thing I'm going to point out is considerations that might prompt you to use an alternative class. In other words, like side effects, for example, or contraindications. And it's important to remember that SGLT2 inhibitors, we always have to consider kidney disease, consider the GFR, and make sure the GFR is not less than 30, for example. If a patient has a history of recurrent genital candidiasis or fungal disease, probably not a great choice. There's a history of diabetic ketoacidosis. The SGLT2 inhibitors may not be the best choice for your patient. In contrast, for the GLP-1 receptor agonist, if you have a patient who has nausea, a history of gastroparesis, gallbladder disease, or is at risk for more gastrointestinal symptoms, probably the GLP-1 receptor agonist, which cause these symptoms, may not be your best choice. And there's in the label a warning to not use GLP-1 receptor agonists if there's a history of multiple endocrine neoplasia 2 or medullary thyroid cancer. That might be a small fraction of your patients, but worth keeping in mind. Okay, so that's how to choose which one maybe not be the right choice, but how do we choose which one is the right choice? Well, of course, there's a major difference here in mode of administration. The SGLT2 inhibitors are oral therapies, while the GLP-1 receptor agonists are subcutaneous injections. That might be important for your patients. And as you heard from Darren, SGLT2 inhibitors really win when it comes to heart failure prevention and renal disease progression. The data for SGLT2 inhibitors really is strong for renal outcomes and heart failure outcomes. Now, for GLP-1 receptor agonists, it's really about weight loss for a lot of my patients. They love the weight loss. So I think about this a lot in my diabetic patients who are trying to help lose weight. That might be one of their primary concerns. And really, this is of great, great value, probably the best weight loss drug ever, frankly, on the market, the GLP-1 receptor agonist for weight loss. And at least in the guidelines here, they gave it sort of an equal rating for each class as far as MACE Prevention. I think we could nitpick on this, but generally speaking, both drugs have a similar reduction of MACE outcomes. The other thing I would add here is I would even just stress the weight loss even more here for GLP-1 receptor agonists, because it really does stand out as one of the only ways pharmacologically that we can safely encourage weight loss in our patients with, let's say, diabetes with metabolic syndrome features. And also point out that GLP-1 receptor agonists are much stronger for A1C reduction. So if you have a patient with a very high A1C, GLP-1 receptor agonists may offer additional glycemic reduction beyond that of an SGLT2 inhibitor. So I'll just point out that I think where these drugs are headed can kind of be inferred by where they're being tested in current clinical trials. There's an ongoing clinical trial of semaglutide in obese patients with a history of cardiovascular disease without diabetes for event reduction, giving you a sense of where the GLP-1 receptor agonists are particularly strong in these obese patients with metabolic risk, but maybe not even diabetes. Well, of course, as we know, the SGLT2 inhibitors are being tested in heart failure populations, even in patients without diabetes. We've seen results for Emperor Reduce and DAPA-HF. We'll probably come back to that. But just an example, GLP-1s being tested in obesity, SGLT2s being tested in heart failure phenotypes. And of course, there's some mechanistic differences. These are just my personal opinions. But SGLT2 inhibitors, of course, work on more of a hemodynamic and natriuretic axis. GLP-1 receptor agonists have perhaps more anti-inflammatory effects, more metabolic effects, as far as insulin resistance and the like. So I sort of, when I think of it, I think as far as anti-atherogenic effects, I think the GLP-1 receptor agonists stand up maybe a little bit more than SGLT2 inhibitors. But of course, when you talk about hemodynamic effects, really, I think SGLT2 inhibitors win out. So I kind of like a very simplistic approach that the American Diabetes Association has put forward. ASCVD predominates, maybe you think about a GLP-1 receptor agonist more. If heart failure or CKD predominates, maybe you think about an SGLT2 inhibitor more. But of course, the future may be combination therapies. So in the guidelines, in the ACC decision pathway, it says it appears reasonable to use both an SGLT2 inhibitor and a GLP-1 receptor agonist with demonstrated CV benefit concomitantly, if clinically indicated, even though such combination therapy has not been studied in a clinical trial. Now, of course, cost is a concern, but really, these are different mechanisms, and the thought of putting patients on both of them, high-risk patients, is appealing. So I'll just conclude this little remarks by saying that most patients in cardiology practice are of sufficient risk to go straight, in my opinion, to an SGLT2 inhibitor or a GLP-1 receptor agonist instead of metformin first. That's my personal opinion there. And I kind of prefer GLP-1 receptor agonists in patients with obese metabolic syndrome features, high A1C, particularly as patients in primary prevention who are concerned about ASCVD. And in secondary prevention, I tend to grab an SGLT2 inhibitor first, especially those patients at risk for heart failure or CKD. So that's kind of my thoughts on that. Real quickly, and kind of in line with what the ACC is recommending in their decision pathway.
Wow, Mike, that was a tour. Thank you so much on this conversation. Dr. Sadhu, this is a cardiologist perspective. Now, you had more experience. I'm sure you use more often a combination or one or the other. What are your priorities and how do you choose from an endocrinologist standpoint?
I was just amazed at how similarly we think. We do look at the same exact risk profile and benefits for the patient, looking at the presence of the prevalence of the atherosclerotic disease versus CKD or heart failure. But to be honest, by the time they come to an endocrinologist, they probably have all of them present.
Right.
So then we go towards the more weight reduction. At least I do. I tend to go to the GLP-1 receptor agonist first, especially now that we have weekly injections and even an oral formulation to help them with weight. And these agents are very potent, as you mentioned, with weight loss, much more so than the SGLT2 inhibitors. And that's a very positive feedback for the patient to do other lifestyle changes. Once they start to see the weight come down, then they are more motivated to other things. And then the whole cycle just improves. So I think if all things being equal, and I could only choose one of these two more expensive drugs, I go for the GLP-1 receptor agonist.
Well, that's a great perspective. Now, as you just mentioned, subcutaneous once weekly. There is a huge advantage of oral intake with the SGLT2, but now coming to the fact that now we also have an oral semaglutide GLP-1 agonist that just got approved. I'm going to ask Dr. Patel to give his insights on what's the latest update on the oral GLP-1 and what's his thoughts and perspective in how that can be adopted in real world, especially from a cardiovascular risk reduction standpoint.
Right. Well, first, thank you for the opportunity to talk with you all. A lot of the people here are colleagues and mentors for me for quite some time. So this is quite an honor to be here. So first, I just want to start with highlighting a few things about the overall class of agents that we're going to be talking about. So I'm just going to go ahead and share my screen here. Are you guys able to see that screen?
Yes.
Okay. So we're going to be talking about the GLP-1 receptor agonist, the glucagon-like peptide 1. So these are in the incretin family of medications that have been around for quite some time for glycemic control. And kind of the story about incretins are basically they're released after the gut sees carbohydrates, and then that leads the pancreas to basically cause glucose-appropriate insulin release, so that we see some improvement in glycemic control. But these incretins actually work in other areas of the body, including the brain, can lead to appetite suppression as well as affect gut motility. So there's a low risk of hypoglycemia because this is going to be glucose appropriate insulin release. And we don't see weight gain. We actually see some weight loss with these agents, as Dr. Mike Blaha just mentioned. And then we've actually seen some cardiovascular benefits. So I'm just going to kind of briefly highlight some of these agents and their corresponding cardiovascular outcome trials. So we have some of which were once daily medications. And then we have others that were once weekly, and they're all shown here. We see that there is one agent specifically that's listed under the once daily and once weekly, which is semaglutide. So the once weekly formulation of semaglutide was a subcutaneous dose that was studied in a large cardiovascular outcome trial. And that actually showed cardiovascular benefits. Whereas the oral form of once daily semaglutide was studied in Pioneer 6, and that study was much shorter in duration and did achieve its primary objective, which was to show non-inferiority for its primary 3-point MACE outcome, but did not show superiority. So important things to note of all of these cardiovascular outcome trials is they were large, and most of them predominantly enrolled patients with established cardiovascular disease, with one outlier, specifically the Rewind trial, which looked at dulaglutide, which is a subcutaneous injection of the formulation. So in terms of all of these agents, some of them actually demonstrated superiority in terms of reducing the 3-point MACE, which was MI, stroke, and cardiovascular death. And specifically the ones to mention and highlight are the ones that are currently on the market and available with indications by regulatory bodies for reduction of cardiovascular risk. Specifically, that would be liraglutide, semaglutide, the subcutaneous formulation, as well as dulaglutide. Now, we mentioned that dulaglutide in Rewind was a large trial that enrolled a large proportion of patients for primary prevention. And so that kind of begs the question, well, can we use these agents for primary prevention in patients without established cardiovascular disease? And I'll be interested to learn more about kind of what the panel thinks. I know Dr. Blaha gave some of his comments, and I think these are very important to remember that these trials predominantly enrolled patients with established cardiovascular disease, but there was no significant interaction based on whether or not they were for primary or secondary prevention, but knowing that each of the trials had a different study population. And so so now kind of talking specifically about the oral versus the subcutaneous formulations of semaglutide, I think this is an important area of discussion for several reasons. One, from a regulatory perspective, the subcutaneous formulation does have an indication for reducing cardiovascular disease risk. Whereas we don't see that indication quite yet with the oral once daily medication. But it's important to recognize that these trials were quite different in terms of their study design and what their primary objectives were. They enrolled similar amounts of patients with a similar proportion of established cardiovascular disease. But it's important to recognize that SUSTAIN-6 was not only event-driven, but it was duration-driven, such that the follow-up period for SUSTAIN-6 was much longer than PIONEER-6. Also, with a longer follow-up duration, the trial accrued a greater number of the primary composite 3-point MACE events compared to PIONEER-6. While PIONEER-6 did suggest that there might be some significant reduction in cardiovascular disease risk, this is being investigated further in a cardiovascular outcome trial now that hopefully we'll have some time to discuss. And then just to kind of give a little bit of the background of what else is out on the market right now, or what other cardiovascular outcome trials that are going on, we are seeing several other agents that are being studied, including epiglinetide, I may not be pronouncing that correctly, in Amplitude O. And then we're also seeing oral semaglutide in a cardiovascular outcome trial called SOUL. And then we're also seeing another agent that's currently under investigation called tirzepatide in a large cardiovascular outcome trial in patients with diabetes. So I think this space has been rapidly evolving. I'm sure that meta-analysis will need to be updated here shortly. And I just wanted to give kind of a brief overview of some of the studies that are going to be coming here in the near future. So go ahead and be happy and interested to hear what others are thinking about these interesting topics.
So this is fantastic. So I have two questions. One for Darren. Yes, in PIONEER-6, we didn't see a benefit from a 3-point MACE, but there was a significant all-cause as well as cardiovascular disease-specific mortality. Does it matter that we need to demonstrate a MACE benefit?
Yeah, it's a great question, and just some history. So the sponsor, Novo Nordisk, actually committed to doing a cardiovascular outcomes trial with oral semaglutide, independent of what happened to the product label for injectable, and independent of what the interpretation of the PIONEER series of trials was. So they were committed, and I have the fortune of co-chairing the SOUL trial with John Buse, and I will tell you, our executive committee was a little bit nervous that as soon as semaglutide injectable got the cardiovascular indication, that our trial would be in jeopardy, because the company is not required to do this trial. But to their credit, we are going to complete this trial. In fact, enrollment is going really well, and despite COVID pandemic, we are making rapid, as planned, progress on this international mega trial. Simply aren't enough events in the PIONEER program in general, and PIONEER-6 specifically. 137 total 3-point MACE events. And if I recall, there was something around 50 to 55 death events. And so there's a lot of play chance when you're having such small numbers of events. The confidence intervals are really wide. And quite honestly, the magnitude of the point estimate of mortality reduction is simply not believable. If I remember right, it's in the order of a 45% relative risk reduction for death. We just don't have medications that reduce death by 45 and 50%. So small numbers going in the right direction, very much optimistic that this will play out to be similarly favorable as the other drugs in class, and injectable semaglutide specifically, but that's why we have to do the trials. And we do have to have some certainty around this if we're going to put it at a level 1A indication for treating such a large global population of patients, just to be certain what we're doing. Can I ask a question of Archana? I learned a lot with the semaglutide program about retinopathy and early worsening, and I suspect I learned about that and then forgot about it with insulin, but it's in all the product labels for insulin. So if you're very poorly controlled with hyperglycemia, let's say an A1C of 10 or higher, there is some risk of acutely dropping the glucose and precipitating early worsening of retinopathy, and that was seen for sure in the SUSTAIN 6 trial. It was mitigated in the PIONEER program, but they had screening retinal exams and screening questionnaires about proliferative diabetic retinopathy. So I wonder if cardiologists are going to be prescribing this. I think that's one important safety concern that we may need to hear more from the endocrine community about, because we really don't want to be blasting away a patient without having had a retinal exam if their A1C is really poorly controlled.
Yes, yes, you're absolutely right. And that is consistent with almost any intervention that we do where we rapidly improve glycemic control. Pregnancy is a classic historical one where the patients are very motivated, therapy is very aggressive, and they can also have worsening retinopathy. So in our practice, obviously, that is one of the screening things we are always aware of and encouraging patients to make sure they're following through with. It's not a barrier if a patient has had retinopathy, but if they're getting active treatment for retinopathy, it is a cause for concern to start these agents, or at least get a clearance from their ophthalmologist before we proceed with them. But it is a well recognized complication that is always kind of forgotten or overshadowed by the cardiovascular benefits, for sure. But when I'm thinking about and talking to patients about risks and benefits, I mean, what kills our patients? Cardiovascular disease. Not to diminish loss of vision, but we can mitigate and help them with loss of vision. But if they are their mortality is high from MI or CVA, that is much more, I think, impactful for a patient to hear. So we will do all the screening and close follow-up around the therapy, but it still weighs heavy for us to make sure that the patients have reduced cardiovascular risks.
So we had one question, and again, this is an open, and actually I was going to ask all of you about this. One of the biggest challenge I see is this tremendous amount of therapeutic inertia, that we have almost about 3 to 5% eligible patients on the right therapies. And I truly see a huge opportunity when a patient's presenting inpatient with their heart disease or heart failure. And I know that right now we do not have any indications, or at least from a practical standpoint, we haven't had any program initiating inpatient, either an SGLT2 or a GLP-1. So this is a question for everyone. What's your thoughts? Do you think that initiation within that index hospital can at least help us overcome some of those gaps, and especially for the ones who are likely to benefit the most? So Darren, Mike, Kershaw, Dr. Sadhu.
Yeah, so I understand you're talking specifically about SGLT2 inhibitors for heart failure admission? Or are you talking about any admission?
So for example, maybe a diabetic patient who present with an MI has an HbA1c of 8 and is moderately overweight, where you can even think about a GLP-1 agonist just for the future risk reduction. The question is, why do we have to wait for an outpatient visit to have this discussion and a consideration of these novel, advanced, but life-saving cardiometabolic therapies?
Yeah, and for me at least, it's two very different answers. We are now routinely discharging patients both from hospitalization for reduced ejection fraction heart failure independent of diabetes status, and patients post-acute coronary syndrome with type 2 diabetes. We are routinely prescribing at discharge an SGLT2 inhibitor. And I think, the SGLT2 inhibitors are so well tolerated, once-a-day tablets, very low risk of side effects. It's a teaching moment, so while they're in the hospital, you can educate the patient about sick day medication rules. They don't take the medicine on days they're not eating a normal amount, warn about urinary hygiene and screening for mycotic genital infections, but pretty simple to initiate. The challenge with the GLP-1 receptor agonist is most, if not all, patients will have some GI side effects early on. For most patients, they can stick through that if they know what to expect and know that symptoms will wane or even go away altogether if they stick with the medication. So what I don't want to do is have an MI patient that I've just initiated a high-dose statin, a beta blocker, an ACE inhibitor, maybe a mineralocorticoid antagonist, and give them a drug that may make them nauseated, and when they get home, they can't tell what's what. And so I'm afraid a GLP-1 receptor agonist in that subacute setting may jeopardize adherence to all the medicines we've just started for the post-acute coronary syndrome care. So I would prefer to get a patient stable, maybe even get them entered into rehab. The beautiful thing about heart failure and acute coronary syndromes is we can have cardiac rehab where we can teach our rehab nurses and personnel conversations about GLP-1 receptor agonists, conversations about walking the patients through the nausea, determining when to titrate up to the next dose. So there's a system in place that we can capitalize on there. But that's my 2 cents. I don't think there's a medical contraindication to initiating either or both medicines at discharge or even during the inpatient stay. But that's kind of how we're skinning the cat in the Parkland system, at least.
So I have a slightly different perspective. I also hold the director for system quality diabetes here at Houston Methodist, all the inpatient hospitals, all 8 of them. One of the things we are very apprehensive about is that euglycemic DKA that could happen with SGLT2 therapies. And when it happens, and it's a small percentage, we're actually reviewing the data for our hospital system now, and it looks like it's under 2% of our DKAs are related to SGLT2 therapy. So initiating or even continuing SGLT2 therapies in the hospital becomes very precarious. And this is really on many levels. One, of course, it's very harmful for the patient, but the risk factors for when that occurs are highly prevalent in a hospitalized patient. And that seems to be NPO status, infections, perioperative status is when these euglycemic DKA kind of take hold. So, and that's common in the hospitalized patients. So I'm a little bit more wary, and although I would say that I actually proposed having it on our formulary, and we have it on our formulary when we first began with empagliflozin and the great data with the EMPA-REG study, I'm really cautious now about whether we should have it. We've actually had some cases where we've had euglycemic DKA occur on a patient continued on therapy in the hospital. And this goes to another level now because in hospital, euglycemic DKA is a major quality metric. So if the patient didn't come in with DKA and they get it in the hospital, it's considered a hospital-acquired condition and is a very bad negative against the hospital quality metrics. So a lot of things playing into this.
No, and these are practical issues we all have to be cognizant. So do you think there may be an opportunity at the time of discharge, or as Dr.
Yes.
McGuire pointed out, maybe at the rehab? So at least the pros and cons we have heard, teachable moment, these patients are at the tip of the highest risk.
And we, I actually just came from our hospital rounds for our diabetes service, and we routinely get consults for patients post-CABG because perioperative glycemic control is so important for them. And part of our rounds is always, is this patient a candidate for GLP-1, SGLT2, or both upon discharge? And we make that recommendation in our initial consultation, but we do it at discharge, to begin at discharge or as outpatient. Now, I get that we may not capture the patient outpatient. They may not come back to see us, and they may go to another provider who may not be so well versed in these classes of drugs and the benefits of them. But I think it's much more safe for the patient to make sure there's good long-term follow-up when they're on the drugs.
So now just shifting gears, and we had a lot of conversation in patients with established heart disease becoming an indication, working hard in getting the right patients on the right med. Now, Mike, just moving a little bit in the direction of patients without established cardiovascular disease. This is an area you and I have been both very interested in. Do you think there is a role of imaging, especially coronary artery calcium testing, something that we had at least identified a tool for using statins and even optimizing blood pressure medications and aspirin? Do you see an opportunity in real world in patients without an established cardiovascular disease where we leverage the calcium testing to identify who should be the candidates, and what's the next steps for us in getting that indication?
Yeah, well, I absolutely believe that, and I do it all the time. I get a lot of referrals for patients with advanced subclinical atherosclerosis as part of my expertise. So I'm getting a lot of patients referred to me with high calcium scores. For example, they commonly have a family history of heart disease, or very commonly a family history of diabetes, and are very insulin resistant. So, right, and let's say they have diabetes, and once again, if they have diabetes, you're going to want to lower the A1C. So there's already an indication for all these drugs for A1C lowering, of course. So the question really comes up partly, if you have a patient with a high A1C who is at high risk for a cardiovascular event but hasn't had one yet, are you going to start metformin, or are you going to go straight to an SGLT2 inhibitor or GLP-1 receptor agonist? That's part of the question to me. And I do use the calcium score in this case, and I'll come back to where that's supported in the ESC guidelines. But so a patient comes to me, higher calcium score than they would like for their age, they have a family history, they have diabetes and are treatment naive. I will use the calcium score, the subclinical atherosclerosis, as a justification to go straight to one of these evidence-based therapies. Of course, the evidence for these therapies outstrips what we know about metformin for prevention of cardiovascular events. So I do feel comfortable. And as I mentioned in my little talk, very commonly these patients are obese. Very commonly those patients have a variety of metabolic risk factors, including fatty liver disease, perhaps. I prefer in that setting usually a GLP-1 receptor agonist, because the risk of heart failure, perhaps, or CKD might not be that high in that patient earlier in the disease process. But they're inflamed, obese, and I love GLP-1 receptor agonists. I've had some incredible success stories, actually, with some physicians, in fact, who come to see me, or other motivated patients who've lost an enormous amount of weight and look completely different. So in the ESC guidelines, the European Society of Cardiology guidelines, they do have a protocol or a pathway for the so-called high-risk treatment-naive patient. So a patient has diabetes, but it's treatment-naive. And it says, how do you select whether you start metformin first, or a GLP-1 receptor agonist, or an SGLT2 inhibitor? And they say if the patient's moderate risk, which basically includes essentially maybe only one or no other cardiovascular risk factors, I think mainly on behalf of cost and so forth, we'd go with metformin. But if the patient is like most of the patients that come to our cardiology clinics have multiple risk factors, of which age can be one of them, they do recommend an SGLT2 inhibitor or a GLP-1 receptor agonist. And they also give an indication for one another reason that you might push the patient down the higher risk pathway is an elevated calcium score. That's a class 2A recommendation in the ESC guidelines. So it's in there in the ESC guidelines that can be one factor to decide to push a patient down a GLP-1 or SGLT2 inhibitor pathway first instead of metformin. So that's the way I use it, Khurram. I get a lot of referrals for these kind of patients. I love the opportunity to use the drugs. It's not necessarily off-label. I'm still using it for A1C reduction, but I'm using it preferentially in a patient that's at risk. So you asked the question, what more data we need? We'd all love to see a trial someday in primary prevention in patients with a high calcium score, really demonstrating a treatment benefit. But even amongst the current treatment rubric, I think we can thoughtfully use these drugs and select patients that are particularly high risk in primary prevention. So that's the way I do it. Like I said, I prefer GLP-1s there. If they don't want an injection, I'd like SGLT2 inhibitors too. And then you get the bonus, weight loss, insulin sensitivity benefits, inflammation that we think all occur. So I'd be curious what the others think, or Khurram, if you use it that way. But that's where I think imaging plays in primary prevention.
So, Mike, just for the benefit of the viewers, one quick question, and then Dr. Patel. Is there any specific cutoff of calcium score that you would advocate for consideration of these medication, or just presence of any calciums?
Yeah, this is a tough question, because of course you have to factor in the age of the patient and the sex of the patient and the race, for example. But I'd say in primary prevention, if they're a middle-aged patient that scores above 100, I'm concerned about that patient, and I'm probably going to be treating pretty aggressively. Or if the patient is younger, on the younger side, and has any elevated calcium that puts them, let's say, above the 90th percentile or so, that's also a patient I'm going to be aggressive early. So I'd say something like a high percentile or a score above 100 puts me in a group where I'm going to be looking at these drugs earlier. Now, if the score is 0 and they don't have any other metabolic risk factors, and they just need to get the A1C down, metformin is a $4 choice that makes a lot of sense. So that's the way I approach it.
Dr. Patel.
Yes, I think those are all excellent points. And I think, when we talk about CAC imaging, whether, these patients have established cardiovascular disease, primary prevention, secondary prevention, I think what we know is that they're at higher risk for downstream events, and we need to do the best by our patients in terms of providing them with risk reduction therapies. I will say that in terms of GLP-1 receptor agonists, there are data to suggest that these are effective in primary prevention patients, specifically in rewind, like we had mentioned earlier. There is a large proportion, the majority of patients actually did not have established cardiovascular disease. And actually the FDA label for this specific GLP-1 receptor agonist, the dulaglutide, there actually is, I believe it's the only GLP-1 receptor agonist that has an indication for CV risk reduction for patients with multiple cardiovascular risk factors, and they don't have to have established cardiovascular disease. And then when we kind of pull all the data together and look at it, it looks like these agents are probably effective across the spectrum with and without established cardiovascular disease. So I think that these agents do have an important role for these patients. And I think when you have patients who have elevated CAC, these are high-risk patients who would likely achieve a greater absolute risk reduction and greater absolute benefits. And then going back to just one of the comments made earlier about the eye disease associated with specifically the GLP-1 receptor agonist, those data were specifically seen in semaglutide. I think in the subgroup analyses, these were basically patients who had some prior eye disease, if I recall correctly. But I will say, to potentially help evaluate this further, this is being investigated in a long-term trial. I think they're looking at semaglutide for about 5 years in a trial called FOCUS. So there will be more to learn about this diabetic eye disease with this agent.
And I'll just make one addition. So in the REWIND trial, there was no interaction by presence or absence of ASCVD, and it was about 50% of the population in each subset, so a pretty balanced cut of the data. But I will make one caution about applying that information, is that the absolute risk difference in the primary prevention cohort was 0.4% over a 3-year period of time. And so the number needed to treat is 220 patients for 3 years, or 600 patients for 1 year to prevent one event. So the cost efficiency really has to come into play. I agree philosophically with everything that Mike said. I have faith that these drugs are at the very least safe. And I think if we prevent atherosclerosis now, then we, over a 10 or 15 or 20 year time horizon, a horizon that hasn't been evaluated in the clinical trials, I'm optimistic, although we have no data, that we will impact cardiovascular outcomes for the duration of the patient's lifespan living with diabetes. The second point I'll make is, for 3-point MACE, there's no suggestion of benefit whatsoever in the subsets from Declare TIMI 58 and from Canvas that had multiple risk factors. But importantly, almost identical risk reduction for heart failure hospitalization and almost identical risk reduction for progression of kidney disease are seen in patients with multiple risk factors. So the primary prevention group for an SGLT2 inhibitor, we can anticipate heart failure risk reduction and kidney stabilization, whereas for the GLP-1 receptor agonist, both in the short but importantly in the long term, probably more atherosclerotic cardiovascular disease risk mitigation.
So I have a comment about the imaging. I think, for us, it's really a moot point, because by the time they come into a diabetologist, they have diabetes, hypertension, hyperlipidemia, and most often obesity. And they have all the multiple risk factors we need. So it's probably, I haven't done enough to say, but it's probably very rare that they would have a 0 calcium score that would sway me from not using one of these agents. So I really don't have the imaging in part of that algorithm.
Well, that would be a good study. Based on our experience, you may find almost 1/3 of these individuals high risk not having any calcium. And of course, our mantra is more around you need events to reduce events. And with the calcium score of 0, if your next 5 to 10 year event rate is going to be low, at least you can be more flexible on some of these advanced therapies. But that said, huge area for us to explore and move forward. Darren, as you was mentioning, I heard renal failure. I know that we've spoken so much about prevention of MACE, we have heart failure, all-cause mortality. It seems like renal dysfunction seems to fly under the radar. And now also, I think so the DAPA CKD study was recently published, and you also had a report from the National Kidney Foundation that you co-authored. So what's in for it from a nephrologist perspective, and can we start expanding the scope to prevention of renal failure here too?
Yeah, I think that's very important for the cardiology community to really get their heads around that these are not just cardiovascular outcomes, but also kidney-related benefits that are more potent than anything we've seen. This eclipses the ACE-ARB effects on progression of kidney disease to the point that even no matter where you start, if you start with an EGFR of 110 or an EGFR of 20, these drugs almost completely stabilize progression of kidney disease, whether it's measured by progression to clinical outcome events, certain thresholds of EGFR loss, or just the slope of the EGFR decline. Any way you want to measure it, there's a consistent effect of the SGLT2 inhibitors. And to the point that Mike made earlier, all of these drugs in the SGLT2 inhibitor class have a contraindication or caution at different thresholds of EGFR. Most of them now are aligned at 30. But we have to remember, most of the time in a product label, the kidney contraindications are based on dose-dependent toxicity concerns. In the SGLT2 inhibitor class of medications, the kidney considerations are purely based on the impact of glucose. And since we're not using these drugs now for glucose when we're targeting the kidney disease progression or the heart failure or the 3-point MACE, we don't care if the glucose doesn't go down a bit. These drugs still have benefit, and we saw that in DAPA CKD. You know, DAPA CKD enrolled patients with an EGFR down to 25 and with or without diabetes. And then in those with or without diabetes and all the way down to EGFR of 25, there was remarkable stabilization of kidney disease. And we've seen the same thing now in the DAPA heart failure trial, where even in DAPA heart failure, they systematically analyzed kidney disease progression and complete stability independent of whether the patients had diabetes or not. The IMPA kidney trial is ongoing, and that's using empagliflozin down to an EGFR of 20. And so, and DAPA heart failure enrolled down to an EGFR of 20. So I think pretty soon in the next year to year and a half, we will likely have an encouragement to use these drugs and can be done safely down to an EGFR of 20. Canagliflozin in the States already has a kidney indication. You can initiate the drug down to an EGFR of 30, and you can continue the drug until initiation of dialysis. And so the FDA has spoken loudly that they believe are confident in the safety profile of these drugs and potential incremental cardiovascular and kidney disease benefits.
In just looking at the time, we may have about a few more minutes. It has been a fantastic conversation. Just to end this discussion, I wanted to bring on Mike. You called up for development of a new cardiometabolic track in internal medicine. Now, of course, the therapeutic options have grown significantly, making the right choices, looking at the side effects, making sure that you're looking at not only for the glycemic control, but cardiovascular, weight reduction, now benefits seen in improvement or reducing the risk of renal failure. Do we need a specialized training, or do we think that we can have a program where it can be led by endocrinologists, cardiologists, and maybe nephrologists in a joint fashion? So what's your thought? I'll also like to get Dr. Sadhu's thought on that.
Well, yeah, clearly in the near term, we need to be repurposing all of our knowledge, you know what I mean, to learn more about what each other does. Me, an endocrinologist or a nephrologist, need to learn those things, and vice versa. So that's the near term. But we've been spending some time thinking about the long term. I think for the long term, we need to be thinking about training a next generation of physicians who are really cardiometabolic specialists. These aren't cardiologists who know a little diabetes. or diabetologists who know a little cardiology, but these are people who are trained and move into a specialty where they're expert in cardiometabolic disease, ranging from type 1 and type 2 diabetes to atherosclerotic cardiovascular disease, kidney disease, liver disease. We didn't talk as much about today, but certainly part of this. So that's how I think the future is, a cardiometabolic physician who can be the home for a cardiometabolic patient. Right now, we're passing from Darren over to the endocrinologist and the nephrologist. That's great. Sometimes the communication is good, sometimes it's not. It would be great to have a home for these patients where they can really get the totality of the care. So we're not wondering if Darren's going to start the SGLT2 or is it me, or is someone else going to start the GLP-1, or am I in charge of that? That's what I think the future is. The future is the cardiometabolic practice with trained cardiometabolic physicians who can take on the ownership of that patient, the totality of their care. Now, of course, that'll take a while to develop. We can start to think about that. In the near term, we just need to repurpose many of our skills, like our cardiology colleagues are doing right now. We're learning about diabetes again, which we haven't maybe thought about for years. So I'm thinking a lot about the future. And this cardiometabolic physician won't be someone, of course, who spends time in the cath lab or the EP lab in training, but instead learns about the cutting edge thought about obesity and about diet and things like that that we just don't get enough of in the cardiology training. So that's my opinion. But in the near term, of course, we need to do what Kershaw and others are doing, is building cardiometabolic clinics and start to round out the skill set with people in the workforce. But we need to train the next generation too.
So again, the future may not be as near, but till then, from a health systems perspective, how can we make sure the best expertise and everybody can come together for a common cause?
So I think it was very eloquently said by Mike that we do need that communication before this becomes more of a well-trained routine practice, even amongst cardiometabolic specialists. For now, we are going to need communication between all of these specialists. And what concerns me the most is, as these are new agents being initiated on patients who are already on other diabetes therapies, particularly insulin, there's going to be a lot of need for titration, and you have to have that knowledge and expertise to titrate. GLP-1s, for instance, they dramatically reduce insulin needs and dosing, and so you've got to be able to be very aware of how much reduction once you get to a certain dose of GLP-1, how to advise the patient. So in the meantime, until we get this long-term program, which I completely support, I do worry that the communication and coordination needs to be very tight so that the patient isn't harmed.
Perfect. Well, it's 5:58. What a fantastic conversation. And thank you so much, everyone, for taking 1 hour at a time. I guess everyone might have been otherwise glued to the internet, looking at news or Twitter, but maybe taking your mind off may be helpful. Tremendously
We may have a new president after this.
And we may have a president after this talk. I have no idea. I haven't checked my Twitter yet, so we'll see. But again, thank you so much, Darren, Mike, Kershaw, Dr. Sadhu joining for us. Till next time. Thank you.
All right. Thanks, everybody.